Good morning, everyone. So my name is Louis Gros. I'm a medical oncologist at the Lausanne University Hospital, and I have had the privilege to be invited to talk to you today about a fascinating topic, the elderly. I love old people, and I also love my mom and my father. Okay. So this project, currently under publication, was conducted with a wonderful I-ELCAP team, with special thanks to Dr. Claudia Enschke and Dr. Rowena Heap for their support. So the good news is that we are all living longer, and as a result, more older adults are diagnosed with early stage lung cancer. However, those patients are often underrepresented or even excluded from clinical trials, as shown in this analysis of 10 years of cancer drug registration studies. So the largest gap between real-world patient and clinical trials population occurs among those aged 75 or older. So starting from this observation that older patients may have been unjustly excluded, including from lung cancer screening program, we formulating the following hypothesis. Curative intent surgery is well tolerated in octogenarians and may provide comparable recovery and quality of life benefits to those seen in younger patients. So for this study, we included all patients with stage 1 non-small cell lung cancer. So cancer equal or less than 30 millimeters on preoperative CT, treated between 2016 and December 2024 using the I-ELCAP data. So we collected baseline data, age, sex, comorbidities, smoking history, nodule and surgical features. And we focused on post-operative outcome, so complications, quality of life at 2, 6, and 12 months, and survival, both lung cancer specific survival and overall survival. So we compared patients aged 80 or older with younger ones using standard tests. And we did survival analysis using the Kaplan-Meier curves. So we included 884 patients, of whom 114 were aged 80 or older. So to summarize this table, median age for younger patient was 69 and 82 for the older group. And the older group included more men, more frequently white patient, fewer current smoker. And in terms of comorbidities, it was pretty similar in both groups, but we had fewer COPDs and lower BMI, and this could reflect survival bias. So this table compares primary tumor characteristic. So we see consistent nodule type, so mostly part solid and solid lesion, similar nodule size, 15 and 16 millimeters, and similar nodule location. But the interesting thing is that there were clear differences in terms of surgical approach, with octogenarians underwent fewer lobectomies and more wedge resection and segmentectomies. And interestingly, the final resector cancer were slightly larger in octogenarians, and their histological profiles differed. They had more adenocarcinoma and fewer squamous cell carcinoma. And they also had more frequently angiolymphatic invasion, so 40% versus 30%. So now the big question is, how did those patients tolerate surgery? So the good news is that the hospital stay was similar, median of 3 days, and the ICU admission and 30-day readmissions rates were also similar. But we need to say that more overall complications were seen among octogenarians, 40% versus 22%. And when we look into the details, so there were a trend toward more complication, more cardiovascular complication, but mostly the big differences were in urological complications. So older patients had more urinary catheter use, and they also had more neurological events. So particularly postoperative delirium, which is well known to be more frequent in older patients. So still the main message here is that octogenarians tolerated surgery pretty well. Let's move on to quality of life. So starting with physical health. So both groups began with similar baseline score, around 50, which is the norm. And they both experienced the expected post-operative drop and then returned to baseline at 1 year, with no significant differences between those two groups. And for mental health, so we see here that there was a mid-decline at 2 months in the octogenarians group, but after 1 year they recover, and this is not a statistically significant differences. So overall, very reassuring findings in terms of quality of life. And what about survival? So here, all 884 patients were included in the survival analysis with a median follow-up of 4.3 years. So the 5-year lung cancer specific survival was similar between two groups. So 94.5% and 94.4%. And in terms of overall survival, so slightly lower in octogenarians, 84.2% versus 87.3%, but not statistically significant differences. Of course, this study has some limitation because we are not perfect. So we had a limited sample size in terms of number of octogenarians, and all those patients were treated in one single health system, the best there is, the Mount Sinai health system, but this included 7 hospitals and 9 surgeons. And naturally, these are well-selected patients, so we have selection bias as only surgical candidates were included. But to conclude, our study included 884 patients in total, including 112 octogenarians. They had similar comorbidities, similar cancer characteristics, but yet they underwent more sublobar resection and they had more adenocarcinoma. But the complication rate, recovery, quality of life were favorable, and the survival outcome were excellent. So this finding supports the idea that curative intent surgery is both feasible and beneficial in well-selected patients over 80. And what's the future now for this population? This raises an important question. Why should we stop screening at 80? And what about the patient who could not get surgery? This is our next project with Rowena. We are looking at in this group of octogenarians, exploring how surgery and SBRT can achieve similarly strong results. And those results will be presented next week at ESMO Berlin and at RSNA later this year. So after all, age is just a number. And with this result, I almost look forward into getting old. I hope I will be able to come, to be invited and to come to speak in the I-ELCAP conference in 2071 when I'll be 80. And finally, a warm welcome to the Octogenarian team, Wenshao Mao, Jiafang Zhang, and Jeffrey Zhu, and to Dr. Claudia Enschke, David Yankelowitz, and Rowena Heap for the leadership, the support, and for the nice red wine yesterday. Thank you very much.